Let's talk about intubation. So as an ER doc, sometimes we have to control people's breathing. Sometimes we're giving oxygen through the face mask, through a tube through the nose. It's not enough. And sometimes patients can't breathe enough, can't keep up, or they're tiring out. And we're trying to predict if the patient's about to get respiratory failure, meaning that your breathing goes from 30, 40 breaths per minute down to 5, then 0. We try to prevent waiting that long, and we try to make the patient comfortable and not more sick, more ill. So I want to talk about intubation. Now, intubation is a skill set that paramedics have done, that people call respiratory therapists who know how to do it. They help manage the vent, give nebulized treatments, give other treatments to prevent the intubation. Doctors in the operating room do it electively, and sometimes emergently. Doctors in the ICU, and us in the emergency room. Nurses also do this as nurse anesthetists under the supervision of anesthesiologists. It's a skill. It's also a skill to figure out when you can intubate someone and when you can't. Sometimes there's rules that the patient has set for everybody else to listen, like decisions, life-sustaining decisions that they've made and put it on paper. But when it's time to intubate, it's a simple thing. Simple to explain, harder to do. It's a skill. So, think of this. No, you'll never see someone look like this. But what you need to understand is this. Right here where I'm pointing at is the glottic opening. This right here is called the epiglottis. This is the base of your tongue. So you would imagine, as you enter someone's mouth, with a device that looks like this. And you're intubating. The tongue is very prominent. If the teeth are very prominent, it can make it difficult. You have to give medications to make them sedated, induce them into a coma, and paralyze them. And that's how they're going to stay still, get the tube in, at least in the emergency room, the majority of the time. So you go in, you're going to see it here, into the mouth. And with this blade, which is the most common blade used, you may see this. You see this, and then as you flex and bring up and lift, you'll see an opening. As it opens more, the more of an opening there is, the higher the chance we can see that and put the tube in without complication. Make sense? So this is called the glottic opening. And between it are cords. They don't always look white or gray, like in an anatomy book. They look like belly buttons. Some are innies and outies. All I know is there's a hole even below this called the esophagus. And I'm not trying to intubate the esophagus. There's a larger hole at the bottom, hiding right there. That's where you feed. That's the tube that connects your food and a liquid from your mouth down to your stomach. Providing oxygen to that is not useful. Make sense? Providing oxygen to this glottic opening is very useful. So I'll show you how I intubate a patient. Okay? So turn this towards here. You can able to see my hands. Okay. You'll see me blade here. Put the tube in. Okay. Does it look that hard? Does it? You don't do that. You do this, inflate, and you connect it to a bag. No mouth to mouth. You put a bag on this, and you connect. Okay?